and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. It's been recognized for some time that immune checkpoint inhibitors used therapeutically in cancer therapy to enhance T-cell activation and increase immune responses to malignant cells can have off-target autoimmune effects. Often these immune-related adverse events, or IRAEs, take on a life of their own, with persisting symptoms long after cessation of the immune checkpoint inhibitor. And that's when the oncologist phones a friend. And you, my fellow rheumatologists, are often on the other end of that phone call. The manuscript we will discuss today is Use of Apremilast for the Treatment of Immune Checkpoint Inhibitor Psoriasis and Psoriatic Arthritis. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures can be found in our show notes from today. I'm excited to be joined today by the first author of this manuscript, Dr. Nilasha Ghosh, and the senior author, Dr. Anne Bass, to share their combined years of experience and expertise in managing IRAEs. Dr. Nilasha Ghosh is an attending rheumatologist at HSS, or Hospital for Special Surgery, as well as assistant professor of medicine at Weill Cornell Medical Center. Dr. Ghosh is a former HHS fellow and has spent her career caring for patients with rheumatologic diseases. Her approach is comprehensive, including pharmacologic and non-pharmacologic therapies, and as a former college athlete, she often incorporates exercise into her treatment. Dr. Ghosh received her master's in clinical research from Weill Cornell Medical College, and her research interests include inflammatory arthritis, rheumatic complications from checkpoint inhibitors, and medical education. Dr. Anne Bass is an attending physician in the Division of Rheumatology, also at HHS, and professor of medicine at Weill Cornell Medical College. She is well known to many in our audience for her extensive experience in medical education, but clinically she also specializes in the treatment of patients with autoimmune side effects of cancer immunotherapy and patients with inflammatory arthritis. Dr. Bass directs the HSS Checkpoint Inhibitor Associated Arthritis Registry, and she's doing translational research to better understand this condition. Welcome to the show, Nilasha and Anne.
Thank you so much, Vicky, for that kind introduction.
Thanks so much for having us.
So I want to start at the beginning of this story and dig into the history of IRAE related to immune checkpoint inhibitors, because this is a relatively new phenomenon. When I look back at the publications, and you began publishing about this phenomenon in around 2018, 2019. And I think, Nilasha, that was right around when you were starting out as a rheumatology fellow. So I wonder whether each of you could share your stories. How did you first notice this phenomenon, and what made you want to focus your research on it?
I guess I'll pitch in first because I'm older, been around longer. So just as a reminder, anti-CTLA-4 first became FDA approved in 2011, and then the anti-PD-1 agents in about 2016-17, but they were in investigational use before that, and Memorial Sloan Kettering is right across the street from our institution. And so I was looking back at, kind of my first publication with Melanie Smith when she was a fellow, and that series, the first patients that we saw were in about 2014. And I became interested because, typically these patients looked very much like they had rheumatoid arthritis or a spondyloarthropathy or a PMR, but we knew it was something different and something new. And we didn't know, our instinct was to manage it in the same way as we did those other inflammatory arthropathies, but we knew it was different and that there was really no textbook chapter on this entity. And so it was both a little scary, but also very exciting, both clinically, and it was clearly an area that we could do a lot of novel research in. So that was the beginning.
And Nilasha, you want to share kind of how you became involved?
Yeah, totally. I actually really remember when I was finishing up my residency at Northwestern, we had talks from oncologists and oncology fellows about these novel therapeutics and how, they can cause inflammation. And, at that point, I had matched into rheumatology and I was like, oh, cool, like this won't really pertain to me very much. But yeah, then I came to HSS, and during our fellowship, we would get consults from our neighboring cancer hospital, Memorial Sloan Kettering, and we would see, these sort of rheumatic adverse events that were a result of the checkpoint inhibitors. And, I really found it fascinating that a cancer therapeutic caused adverse events that mimic our diseases, as Anne was kind of saying. Normally, they're therapeutics to treat, rheumatoid arthritis and whatnot. So, yeah, I found that very fascinating. And I was in my first year fellowship looking for kind of an area of research to dive into as part of the fellowship. And I meshed well with Dr. Bass, and I found this topic interesting. And so we started working together. And 7 years later, here we are.
That is great. For those of you who can't see on the podcast because it's audio only, Anne is smiling in the background, listening to Nilasha tell that story. So, Nilasha, I have a couple questions for you about this particular manuscript. How common is it for someone to develop psoriasis or psoriatic arthritis in response to an immune checkpoint inhibitor?
For psoriasis, there was a study that was done. It was a pharmacovigilance study, which is when, actually providers send in reports of adverse events. For psoriasis, there was a study that came out that about 4% of patients who experienced an IRE developed psoriasis. Of those, around 70% of patients had pre-existing psoriasis. So that means about 70% of patients had a flare of their sort of underlying disease, and about 30% of patients developed what we call like de novo psoriasis as a result of this checkpoint inhibitor. Psoriatic arthritis, it's a bit more complicated to answer because it sort of depends on what we call psoriatic arthritis. If it's an inflammatory arthritis that's associated with psoriasis, or in a patient that has a past history of psoriasis, that is like more clear. As we know, some rheumatologists may call an oligoarticular arthritis that, involves the large joints in an asymmetrical fashion, a psoriatic phenotype. So the exact incidence is a little hard to determine for this subset. What we can say is, inflammatory arthritis as a whole occurs in about 4 to 5% of patients that develop an IRE. And a systematic literature review that Anne and I did when I was a fellow estimated that about 20% of those patients of these inflammatory arthritis have a psoriatic-like phenotype.
Yeah, it's really kind of helpful to put it in context. And I'm wondering, just as a follow-up to that, the folks who had pre-existing psoriasis, was it that they had kind of not really thought about it in heading into this therapy, or is the oncologist aware and they're moving forward anyway?
Psoriasis, and I will say all autoimmune disease for that matter. So when the trials for checkpoint inhibitors first came out, patients with autoimmune diseases were excluded, right? They didn't know if this would confound things and whatnot, and didn't want flares of disease. Now, psoriasis in general, relative to other autoimmune diseases, is on the more mild side. It is
Mhm.
for the skin. So I don't think that was, if it was an exclusion, was anything that the oncologists were worried about should it flare. Now, definitely when we talk about inflammatory arthritis, now those patients were definitely excluded from those early trials of checkpoint inhibitors.
And so tell us, why is it important to look at Apremilast as a therapy for immune checkpoint inhibitor psoriasis and psoriatic arthritis? What is it particularly that makes that an attractive therapeutic option for people struggling with this complication?
Right. So, as you had mentioned actually in your intro, inflammatory arthritis as a result of checkpoint inhibitors can last for long periods of time, even after a checkpoint has been discontinued. And that is actually unique, I think, to arthritis relative to some of the other immune related adverse events like generalized rashes or hepatitis or whatnot. And so it falls on us rheumatologists to be able to treat this condition, especially if it's really affecting the patient's quality of life. Now, when we're treating this condition, patients can still have active cancer. They can still be getting their immunotherapy. Or if they're not getting their immunotherapy anymore, maybe the cancer had responded in a very good way, and the immunotherapy is still there in their system exerting its effects. We have to be wary of, immunosuppression that can potentially negate the positive effects of the checkpoint inhibitor.
Yeah.
So, Apremilast, it's an attractive option of a, disease modifying agent that doesn't suppress the immune system. And because it's shown some efficacy in traditional psoriasis and psoriatic arthritis, we thought perhaps it could translate to work in some of these patients.
And so tell us how you designed this particular study. It was a multicenter observational study. Why was that? And then who did you collaborate with, and why did you particularly choose those centers?
So, as I mentioned before, so inflammatory arthritis is not very common relative to other IREEs, so 4 to 5% of IREEs. And so generating a large enough cohort for efficacy trials for treatments is extremely difficult, let alone for the certain subset of, inflammatory arthritis that we're looking at for this paper. We are attempting to do observational studies at a national level with something called RADIOS, which I believe stands for Rheumatic Adverse Events as a Result of Immunotherapy Observational Studies. It's a handful, so we just call it RADIOS. But this is a multicenter consortium of academic centers all across the country that are prospectively collating their patients that have rheumatic IRE. And we're doing this in order to gain the numbers to be able to answer questions regarding disease course and effectiveness and safety of medications in a more meaningful way. So in our discussions, we have, regular discussions where we all meet up. We found that Anne and I at the Hospital for Special Surgery, along with Dr. Puncti Reed at the University of Chicago and Dr. Jeff Sparks at Brigham, had used Apremilast at one time or another for the treatment of inflammatory arthritis. And there was really no data or literature out there about its use in terms of efficacy or safety or tolerability. So we thought that this would be sort of a good forum to be able to use the data that we've already been collecting for this registry and try to answer that question with Apremilast.
Yeah, I agree. I love it because it's very real world data and yet making that data usable to inform the future. So tell us a little bit about the patients in this study. What cancers were they being treated for? Did any of them have psoriasis or psoriatic arthritis before the treatment? And then which immune checkpoint inhibitors were they receiving? Was it the same across the board? And were they having other adverse events?
Yeah, great question. So even pulling all of our patients, we really came up with 21. Most of them were being treated for melanoma, lung cancer, or like genitourinary cancers, though there were a smattering of a variety of different cancers. So really, really all pretty different. And these patients they had received Apremilast for either checkpoint-induced psoriasis, psoriatic arthritis, or both. About 2/3 of them got monotherapy with a checkpoint inhibitor. That means they received either a PD-1 or a PD-L1. And the other third of them received what we call combination therapy, which is a PD-1 or PD-L1 in addition to a CTLA-4 agent, which is often ipilimumab. About 76%, so 3/4 of the patients had a pre-existing autoimmune condition, which was either psoriasis, psoriatic arthritis, or inflammatory bowel disease, since we often lump that in there, indicating that their immune-related adverse event was probably a flare of their underlying condition. A little less than half the patients had experienced other immune-related adverse events, most commonly thyroid disorders, colitis, and adrenal insufficiency. We
Yeah,
made sure
interesting.
to yeah. So we made sure to exclude patients that we knew were being treated for other immune-related adverse events. At the same time, if they had developed like psoriasis or psoriatic arthritis, just so that there wasn't any like confusion in terms of what something was being treated for.
And so what happened when you looked at the outcomes of Apremilast therapy in this cohort of patients?
Yeah. So we decided, because there were the majority of patients, 3/4 of them had pre-existing disease, we really wanted to kind of separate those patients from the patients who had nothing and who developed really what we call de novo, psoriasis or psoriatic arthritis as a result of the checkpoint inhibitor. So for the 5 patients that didn't have any pre-existing disease, the response for both skin and or joints with Apremilast was what we called a partial response. And so what does partial response mean? So this means that they had some sort of improvement, but it really did not go into remission. And how this grading was determined is we use something called the CTCAE rubric. It's the Cancer Therapeutics Adverse Events rubric that is often used in the cancer world, where grades are assigned based on an adverse event's severity. So on average, patients had a grade severity of about 2, though there were smatterings of 3s and 1s. And so if there was a partial response, it went from something like a grade 2 to a grade 1. A complete response would be something that went from like a grade 2 to grade 0. So going back to our patients who had no pre-existing disease, 4 out of the 5 patients had developed a partial response, meaning that there was some improvement, but it didn't really all clear up. However, for these patients without pre-existing disease, the majority of them really couldn't tolerate Apremilast due to the side effects. And so 4 out of 5 of them had to discontinue it. So then you go to the patients who had pre-existing disease. And there were about half who had a flare of their underlying disease and had psoriasis as their manifestation, and half who developed psoriatic arthritis as their manifestation with or without psoriasis. So, really, one group was psoriasis only, and one group was psoriatic arthritis with or without psoriasis. And so we tried to see if there was any differences between these two groups to see if anything significant kind of came out. What we had found was that of all the patients in the psoriasis only group had either a partial or complete response to apremilast in terms of skin clearance. Whereas when you look at the psoriatic arthritis group, only about half of the patients had a partial or complete response. So there's just more patients in the psoriatic arthritis group that did not respond as well or at all to the apremilast. In fact, 3 patients who had pre-existing psoriatic arthritis, apremilast was not effective at all. And what we also found was that among the whole cohort of patients being treated with apremilast, about a third of them had side effects so severe enough that they had to discontinue the apremilast because it just wasn't able to be tolerated.
This is a small study. What do you think is important for our listeners to know about the limitations of this study?
Yeah, of course. As you mentioned, it is a small study, and despite pulling our patients from like 3 academic centers that see a lot of these kinds of things, the use of apremilast, since there really hasn't been any literature on it, we just didn't have a lot of patients. So we really shouldn't draw high grade conclusions from this. But what we can say is that there's a lot of heterogeneity, right? From the very beginning, all the cancers are very different. The presentations are very different. Some people had a patch of psoriasis, some people had 20% of body surface area.
Okay.
Even the psoriatic arthritis, the joints that were affected, the number of joints, pre-existing disease versus not. So essentially, there's a lot of heterogeneity in here. And so on top of that, there were patients who were getting treated with other DMARDs at the same time, even dosing of the apremilast, whether they had to take a break because of intolerabilities. So I think, attribution of improvement and non-improvement could really be difficult to apremilast alone. This is also just a very different patient population than what we normally see. It's not this nice set of very homogeneous patients. And they're also experiencing, other side effects, like maybe the checkpoint inhibitor is causing, some GI upset, and it's really the checkpoint inhibitor that's doing it and not the apremilast. And so I think attribution is a really difficult thing. One other thing is, whenever we're talking about therapeutics in cancer patients, a data point that it's important to recognize is what we call cancer progression, or the oncologists, they like to use progression-free survival or overall survival. And while we really don't have the number of patients to draw, heavy conclusions about this, we did note that about a third of patients at the time at the last follow-up did have progression of their disease or had died. Now, again, that's not because of the apremilast. I don't think we can say one way or the other that it was helpful or not helpful, but there's just a lot of confounders due to that heterogeneity and concurrent medications, and just what we call immortal time bias, which is inherent in observational studies like this, unless it's controlled for with like a landmark analysis or like a time-dependent variable.
Yeah, I think really important to take in consideration, and that nicely transitions me to pull Anne back in now, because Anne, you direct the HSS Checkpoint Inhibitor Associated Arthritis Registry, which is obviously a great way to start to gain over time some more long-term follow-up data on people who develop these complications. I wondered if you could share how many people are enrolled in that registry, tell us about how it started, and how have you, over the last several years, been able to shape the understanding of these conditions?
The HSS Rheumatic RA Registry, we initiated it in 2018. And at that time, I was actually still a program director. And I remember Kimmy Chan was sitting across the desk from me, or we were talking about these patients. I think Dave Fernandez was with us as well, and chatting about how it was it was really important that we begin to study them, and we began to talk about starting a registry. And at the time, my plate was very, very full, and I wasn't sure that I could take on yet another thing. And I remember Kimmy was very enthusiastic, and she said, "I'll do it with you." And so we did, and I'm very grateful to her for her enthusiasm. We started up the registry, which, from soup to nuts, to create all of our data collection forms and et cetera, et cetera. We began collecting information on patients. At that time, we got some internal funding from the department, which was, invaluable. Really, I guess over the next 4 years or so, recruited 200 to 300 patients into that registry. And as Nilasha mentioned, around that time, 2022, 2023, a number of centers around the United States had become interested in these rheumatic immune-related adverse events. And so under really the leadership of Hopkins, we formed this national registry, RADIOS. So we then, moving forward, began enrolling our patients into the RADIOS registry. And since 2023, I've enrolled another 200 or so patients. The number of referrals is kind of going up exponentially as these agents are approved for more and more cancer indications. And RADIOS itself, to which we have access to all of the data from all of the sites, we've just passed the 1,000 patient mark. And of those, about 500 have inflammatory arthritis or PMR or arthralgia. And so it's really a very, very rich database in which to do observational studies which can be very valuable in and of themselves just because the numbers, and also can be hypothesis generating. And hopefully in the coming years, we will begin to do prospective trials and not only observational studies, especially in the area of inflammatory arthritis.
Yeah, no, that's amazing. And I had not realized that registry was now so large. That's actually really incredible work. I do feel like this type of a ground up registry is the real way to better understand that sort of inception point of when these inflammatory reactions start to tip off. And it's probably going to be very informative at understanding the inception point of autoimmunity, perhaps, because you really know at what point did you start this drug and how quickly after checkpoint inhibitor initiation did the autoimmunity develop. So I'm sure you're going to have rich data still to come from that. Rheumatology has been lagging behind a little bit compared to the cancer field in precision diagnostics. While we do have targeted therapies, we don't really molecularly immunophenotype people ahead of your therapeutic decision-making the way that you do in cancer. And as someone who's practiced rheumatology at one of the top rheumatology centers in the US and who works across the street from some of the premier oncologists treating people with these adverse events from checkpoint inhibitors, what do you think we would need to bring autoimmune disease care closer to the paradigm we have for cancer?
That's a great question. I guess first I'll make a little bit of an excuse for our field in the sense that cancer is far more common than even a condition like rheumatoid arthritis, which is among our most common rheumatic diseases, if you set aside osteoarthritis. So fewer patients, a lot of disease heterogeneity, but fewer patients, and therefore less funding. And also these conditions don't kill patients. And so, at least in the case of inflammatory arthritis, that's not necessarily the case for some of the other conditions. So I think funding is an issue because the diseases are rare and potentially lifelong chronic as opposed to short-term lethal. So that's one thing. But I do think that there is a lot that we can learn from oncology. And I think our field is doing a much better job of facing up to the rarity of our conditions and forming consortia. So RADIOS is such a consortium in relation to checkpoint arthritis or rheumatic IRE, but there's the scleroderma group, there are the lupus trials groups, the vasculitis field is very collaborative as well. So investigators and clinicians are really banding together to try to increase numbers and create platforms really for better studies. So that's one thing. Also kind of novel approaches to clinical trials because the diseases are rare. So some of these platform trials that are being done, for example, in scleroderma, where you create your consortium, you have your infrastructure for the trial, and then you can, as new drugs come into development, use the same control group and then test drug A and then later test drug B, et cetera, without having to go through the entire create new infrastructure every time you do a trial. So I think that's really promising. The last piece, I think, is kind of the culture of investigation. As I've come to work with oncologists more and more, oncologists, even out in the community, almost, maybe not all in the community, but they're always doing studies. They're always enrolling their patients in studies. And it's almost the exception that is not enrolled in a new study. In rheumatology, because our diseases are very complex, and especially we almost come to think that, nobody can take care of my patient as well as I can. I know all the details. And that may be so, but it works a little bit against this idea of the community needs to understand how it advances the field in general. And so it's in the patient's broader interest to enroll them in studies. So I think that takes time to develop, but I think that's an important element as well. I think in terms of, you mentioned genetic testing, which has been so amazing in cancer and allowed them to develop targeted therapies based on the mutations that they find in the tumor. I think that the work that's being done through AMP, the Accelerating Medicines Partnership, which is multicenter, NIH-funded study, and then there's AMP1 and there's AIM, which is the second part, where they are really doing deep phenotyping of a few autoimmune diseases, including rheumatoid arthritis and lupus. And really, in the case of rheumatoid arthritis, beginning to understand that it is not a homogeneous disease and not just seronegative versus seropositive, but rather some patients whose synovium is full of lymphocytes and others that are relatively pauci-immune. And as we understand better these different phenotypes, it may explain why some of our patients respond to therapy X and others to therapy Y. And hopefully down the road, we'll be able to immunophenotype our patients and decide on day one what the best therapy is for them. At the moment, that would require a synovial biopsy and also an understanding of what the best treatment actually is. We're a little bit behind in terms of synovial biopsies, and hopefully they'll maybe find a liquid biopsy, just a blood test that can determine what the best approach is to treatment. But I think we're at the beginning of that kind of individualized or therapy, but really just kind of where oncology was 20 or 30 years ago.
Yeah, no, I find it fascinating that you kind of thought about this cultural shift, I'll say, that needs to happen and kind of agree. Because in actual fact, I'm going to take a slight issue with the numbers that you were quoting and that our diseases are so rare, but collectively, actually, that's not true. If you take all autoimmune diseases together, is a group of conditions that affect more than 50 million people. They are the most common group of chronic conditions affecting the American people, and yet we don't study them anywhere close to the same way that we study the group of diseases that fall under the umbrella of cancer. I think that one of the things oncology did very early on was this kind of coming together of we're looking after all these different diseases that affect different organs and are very unique. Melanoma is very different from a genitourinary cancer or from breast cancer, but we're going to collectively bring them together under the umbrella of cancer so that we can build the infrastructure and the research structure that needs to happen in order to move the field forward. And do you think that kind of looking at what that early decision did to change the field now 30 to 40 years later, kind of with the view of hindsight, it gives you a very different look at the picture. I hope that maybe we could get to that place one day for autoimmunity. I'm going to change direction now, just talk a little bit about you and your career. And you are one of the distinguished educators in rheumatology. I am wondering, what first drew you into rheumatology as a field, and how did your early clinical experiences influence the type of physician you wanted to be?
I actually decided very early I wanted to go into rheumatology. I became interested in immunology in college. although I was an art history major, and I have to confess, I actually never took an immunology course. But at that time, which was I will confess my age, late 70s, early 80s, it was really the birth of what we think of as modern immunology. And so it was kind of in the news. It was all around us. People were getting Nobel Prizes, and it just seemed like a very exciting area. And the summer, we had a break between our first and second year of medical school, and I worked in a lab in the rheumatology division at Columbia. And in addition to doing the work that I was doing, I was able to attend their clinical rounds. And I felt like I have met my people, and this is just the most interesting field that I could possibly imagine. It just covered all the bases. The conditions were interesting. They were manifestations of the immune system, which interested me. And then the people were wonderful. They were at Columbia at that time. Susie Goodman was doing her fellowship. Susie is now professor at HSS. One of my close colleagues, Ed Parrish, was running a lab there. Rima Koppelman was fellowship program director and was a good mentor to me. And Dan Littman was working in Richard Axel's lab at the time. And so there are just a lot of wonderful people. And Ralph Bloom was kind of the clinician extraordinaire at the time. I just loved everything about it. I loved the people, the environment, and the underlying science. I think over the years, I was lucky to become the program. I do enjoy teaching. I love to take care of patients. I do and very much enjoy teaching. And when I came to HSS, which was a little bit later, certainly in my career, Steve Paget, who is really the rheumatology educator extraordinaire. And we have these weekly case conferences. And not only were they interesting, and I learned a great deal from him, but I watched his teaching style, and I can't hope to ever replicate it. And we have different personalities, but that definitely influenced the ways in which I teach, and then kind of the storytelling that goes along with it. So those were some important people in my early career.
It's wonderful to hear you tell that story. I just was like absorbing all of those names. I want to bring Nilasha back in as well and just kind of hear from both of you about what you think is really needed and what perhaps our field needs to do better to support the next generation of rheumatologists. And Anne, I'll let you go first, but then I also wanted Nilasha to answer that question.
Yeah, that's a tough one because as we all know, these are tough times, whether you're on the research side or whether you're on the clinical side. Physicians are stressed. So I'm not sure I have a great answer, but I guess, I'll start with the simple thing, which is I really enjoy what I do. And I think modeling that enjoyment, taking pleasure in my work, it's easy for people to get down given the external environment, but just remembering that we're very, very lucky to have such interesting work and to be able to help patients feel better and to do exciting science. So keeping positive is important. And I think kind of along those lines, also helping young rheumatologists or pre-rheumatologists to find mentors. I can't say that I had that many I've mentioned people who were important in my early career, but identifying a mentor who does things that you might like to do in the future and whose personality meshes can be, even if it doesn't even have to be somebody at your own institution. I've had people reach out to me from other institutions, actually, who are interested in doing the kind of work that I do. But finding somebody who has more experience and can make suggestions along the way for career advancement can be helpful. And then, in the research area, and I know you're very aware of this, we certainly don't want to lose our early investigators, either to clinical work if they really want to be an investigator or to industry. And so whether it's internal departmental grants or whether it's bridge awards, the ACR Rheumatology Research Foundation has been very proactive in establishing bridge awards for people who don't get their K award on the first time around, and R bridges as well, to try to support those early investigators, because the pendulum always swings and things will get better. And you just want to carry them through this difficult time. And for clinicians, the ACR is very active in advocacy to support the needs of practitioners, not only investigators, but practitioners. And so that's another area where people can help, is participating in those advocacy activities.
Yeah, Nilasha, did you have thoughts? You've probably got a slightly different perspective. A touch earlier in your career, do you have thoughts about where there are gaps and what's needed to really support the next generation?
Yeah, I'll say, Anne, that was really well said. And I will piggyback a little bit on Anne in what she said about mentorship. If it wasn't obvious, Anne is my mentor. Um, she's been absolutely fabulous, not only in this checkpoint inhibitor research that we've been doing, but as she said, she was the program director when I was a fellow. And I think we meshed really early on, and I really admired her style and talked to her kind of at every step of the way. I do think that's important. I think Anne touched on, what could be done for early investigators. And something I thought about for some of our pre-trainees, as she had mentioned, or some students who are thinking about rheumatology, or our medical residents, or even some of our early fellows, is I think one of the things that we all wish we had more of, and probably one of our greatest resources, is time. I think it would be great to be able to provide time for our trainees to explore a variety of different things, whether it be research or, having clinical exposures or going to annual meetings and whatnot. And I know these opportunities exist, and the ACR does a good job, I think, to provide some of these. But I can see with sort of increasing responsibilities, clinical side, or increasing responsibilities of our trainees, both professionally and even outside of work, I think that the time to be curious is limited. And so time to be curious and fostering that curiosity, I think would be good for our trainees.
I guess, and this kind of jumps off of those same ideas, what advice does each of you have for the early career physician, already a rheumatologist, perhaps maybe in fellowship or first faculty position, who wants to build a career that blends clinical care, research, education, and leadership? You have any tips on how to juggle all those priorities? And I'll let Anne answer first and then Nilasha.
Well, I'll say first of all, and Nilasha can confirm this. I told all my fellows, don't try to do what I did. It's very hard to. It's not that it's hard to juggle, but it's in this current climate, it is hard to blend all of those things. I'm thrilled that I've been able to do that. It was a kind of an odd trajectory that it worked out. However, if you really do want to do that, and the trajectory that I followed, what I would suggest is to develop an area of clinical expertise, even if your interest is in education, to develop an area of clinical expertise that will make, in your clinical work, make people want to refer their patients to you. You will develop clinical expertise, of course. And then out of that clinical expertise grows research questions. It also means that you can teach your trainees, bring that expertise to your trainees. And then what happened in my case was that out of areas of clinical interest, which kind of evolved over time, I began to do some clinical research, kind of learning kind of on the ground, as opposed to through coursework, through collaborations with other people. And I gradually developed some research expertise just through through practice. So that's kind of the education and research piece. As far as leadership goes, I mean, I think regardless of what your career aim is, getting involved in the ACR is just a fantastic thing to do in terms of it's fun, it's a great way to network, and it does have the potential for leadership roles. And there are places to volunteer, no matter what your interests are, whether they are clinical, in advocacy, research, education. There are niches for everybody. When I became a program director, when I first became an associate program director, my first program directors conference was like, wow, there are 150 people just like me, and they're all very nice and really willing to help me out. So that was really an amazing experience. There are niches like that for people, no matter what their interest is.
Yeah, amazing. Nilasha, did you have thoughts? You're someone who used to be a competitive athlete, and so I appreciate that this career in rheumatology is not quite like competitive swimming. It's a bit more like swimming upstream. But do you have any lessons learned from that phase of your career that you've carried forward into your rheumatology life?
I am competitive. And coming into fellowship and having Ina as my mentor, I was just like, wow, this is a person who does it all. Like, I can do this. Like, I want to do this as well. And so I had this sort of vision of being able to do research and taking care of the patients and being a prominent medical educator. And Anne did give the warning. She's like, it's not that it's not feasible. It's just, it's the climates can make it a bit difficult. I learned that as I entered as we would say, the real world. So I think advice wise, what Anne said is beautiful in the sense of like, find something and do it well. If you do it well, people will seek you out for that, whether it be through referrals or patients talk to each other. And once you do that something really well, you will find where the gaps are. You will ask the right questions to be able to, if not lead clinical research, right? Because we all know that it's very difficult to be able to be a full-time clinician and a full-time researcher, but at least be able to be involved in it. And I would say that choosing sort of one path, which whether it be all clinical or all research or, a majority of one of those, I think that finding opportunities to incorporate the other pathway, like other aspects of the pathways, is really important if they bring you joy, right? Not doing it for padding your resume, but like truly if it brings you joy. And I think these other avenues really can provide that variety and, mental stimulation outside of the monotony of doing like one thing. And that can potentially help with burnout. But I really enjoy seeing patients and I really enjoy being involved with research, even if I'm not the lead investigator of, every single thing that we do. So I think that there can be joy found in collaborations and being helpful to other people and other providers.
Definitely really appreciate those two perspectives because they kind of weave together that phrase that Anne said, that the pendulum always swings. And so if things are going well in the research, they might be more of a struggle on the clinical side and vice versa. So really helpful advice. I want to thank you both, Anne and Nilasha, for taking the time to talk to us today, for sharing your work and for sharing all your incredible insights. Thank you.
Thank you.
Thank you.
And as we wrap up, I also want to offer a heartfelt thank you to everyone who teaches us to become the best rheumatologists we can be. Our mentors, our professors, our fellowship directors who guide us in our careers, our colleagues who keep us learning, and our patients who offer invaluable lessons in science, complexity, courage, and humanity. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Rheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.
This podcast was edited by Resonate Recordings.